We're Pacific Bariatric Surgery. There's 3 surgeons in our group. Dr. Fuller joined us about 6 months ago. Some of you may not know him. But he's real good. He's had a number of years' experience at Scripps Clinic. He's been doing it there. So all of us have been doing this for a number of years. And we do all our surgeries here at Scripps Mercy. And we've been doing them here for about 24 years now. So everybody in the hospitals has a lot of experience with this. Each of our anesthesiologists, we figured out the other day, have done at least 400 of these cases. So they're well prepared. Our nurses have taken care of over 18,000 patients in the floor. So everybody's well equipped. We are a center of excellence. Every 2 years we get inspected. They come around, we're due again in October, and they look at our statistics. They look at the doctor's statistics, also the hospital, and make sure the hospital can take care of patients that are overweight and have certain problems. So make sure this is in any hospital you're looking at, the Center of Excellence. It's like getting a rating from a restaurant. It's the same type of deal. So just the first part of this is just to give you a little idea of the history of bariatric surgery, how this all came to be. And we'll just go over it very quickly. But bariatric surgery has been around for a long time. This actually started back in the late 60s, early 70s. People started doing a type of bariatric surgery. But it really didn't get going until the early 90s when the National Institute of Health had a meeting. It was a big meeting. And the idea of the meeting was to determine, was there any place even for surgery to treat obesity at all, or should people just diet and exercise? And what they determined a number of things at this meeting. And one was that a hospital that does this has to be well equipped. The hospital and the physicians. You have to have medicine backup, a facility that can handle problems, things like big beds, big CAT scanners, different things that you need. You have to have nutritionists, exercise programs, support groups. Until then, doctors would just do these surgeries and say good luck and hope you do well. This is a never-ending battle. You have to battle this your whole life, whether surgery or not. And so the big thing at that meeting was that you need support. You have to support patients forever. It's not just do it and go home. The other thing, and this is back in the early 90s, they determined that this is actually a disease process. Up until then, and you probably still hear this now, you're overweight because you eat too much and you don't exercise. And that's there's that bias out there. But what they did back in the 90s, they actually said this is due to a lot of causes. There's genetic, it tends to run in families quite a bit. It's a little bit more common in females, particularly you gals that have had kids, how it gets after kids. There's metabolic factors that we're just beginning to search. This is environmental. There's a fast food restaurant in every corner. We're all busy. That's what we eat all the time. It's simpler and easier. And there's neurologic factors. The good part of bariatric surgery actually is that in the last 10 years, there's been more research done on this than ever before. Ever before. This is the big public health issue now. It was smoking for a long period of time. Now it's this, and the fact that diabetes is frequently associated with it. So they're doing a tremendous amount of research. For example, they're finding out a lot about the intestines that we never knew. It used to be felt intestines, all they did was absorb food. They probably do a heck of a lot more than that. And so they're just scratching the surface, but we're going to know a lot more about this in the next 10 years. And then at that meeting, they also said, if people were going to have surgery for this, what were the criteria? You need criteria, because there are some risks associated with this surgery. So what they said was that if people were 100 pounds overweight or 75 pounds overweight with medical conditions associated with their obesity, that they should be considered for surgery. So 100 pounds overweight. Now the problem with that is every insurance table had different measurements for what 100 pounds overweight was. So then they came up with a BMI, and you take your weight and your height, and you come up with an exact number. As an exact number, it's 40 or 50 or 20, whatever it is. And so 100 pounds overweight is essentially a BMI of 40. So that's what the insurance companies often look at as a BMI of 40, or a BMI of 35 is 75 pounds overweight. And that if you have comorbid conditions associated with your obesity, that you should be considered for surgery. Probably a healthy weight is somewhere between a BMI of 22 and 25. That's what you're trying to get to. That's considered normal. Some of your supermodels probably are in the range of 18, 17. I don't think they're always real healthy, but that's about where they hang out. But 22 to 25 is what you're trying to get to. So it's an exact number. We can take your height and weight and come up with a number, and you'll know where you stand. And these are just some of the conditions that are associated with being overweight, and there's a lot more, and particularly they're finding out a lot more. But things like sleep apnea, high blood pressure, diabetes, heart trouble, arthritis, high cholesterol, and there's all sorts of other ones, pain in the joints, and you just can go on and on and on. It's interesting how much better most of these get when you start dropping the weight. Diabetes is a real incredible one. After a lot of our patients come in on insulin or at least on medications, and many of them go home off those medications. So it's pretty incredible how quickly a lot of these improve when you drop the weight. Life becomes a lot better, I'll tell you. It really becomes better. Now, what I want to do real quickly is go over how this started. How did the operations begin? And I think it'll make more sense to you then to know why do we do the operations that we do today. I think it'll just give you a little bit of information. So back in the 70s, they did this operation. It really went by the name is the IJ bypass or the intestinal bypass. And something to remember, this is your esophagus, this is the stomach, this is the small intestine because it's small in diameter. It's actually long, it's about 25 feet long. And this is the large intestine or colon. The thing to remember is food is absorbed in your small intestine. Your stomach just grinds the food up and gets it ready to be absorbed from your small intestine. And the colon is just kind of a reservoir, so we're not going to the bathroom all the time and holds things in for us a little bit. So the first operation was to make the small intestines shorter. And the feeling was people could eat, it would just go right through them. They wouldn't absorb much of the food, and they'd lose weight because they weren't absorbing it. So they would take this 25 feet of bowel and shorten it so it was only about 18 inches long. Food would go through about 18 inches. And the idea wasn't too bad. Most people did lose quite a bit of weight. The problem is it led to malabsorption. And malabsorption can cause a lot of problems. People get dehydrated. They ended up with electrolyte problems where their sodium and potassium were bad. A lot of them went into renal failure and kidney failure and had to be reconnected. Some went into liver failure. So a lot of patients became deathly ill. And because of that, malabsorption kind of died off fairly quickly because a lot of people were getting worse than they were before. So that was the malabsorption procedure. So then back in the late 70s, 80s, they said, what if we don't cause malabsorption, but what if we just make the stomach smaller? And so people can't eat as much. And if they fill up quicker, cut back on the volume of food, and if they're eating the right things, then hopefully they'll lose some weight. So they did what they called the gastric stapling. And this is where you'd staple across the stomach and you'd take a couple staples out. So food would come in this way and kind of sit here for a while and then slowly empty. The idea was pretty good. People didn't get sick. And they lost quite a bit of weight after this surgery. The problem is, remember the stomach's a grinder. It grinds up the food so it's kind of moving around. And unfortunately what would happen is the staples would kind of loosen and pull apart. So the problem with this operation was the failure rate was really high. And people would lose weight and then they'd come back a year or two later and say, geez, I gained my weight back. And you do an x-ray and the stomach looked, normal again. It just looked basically like nothing had been done. So, but the idea that restriction was a good idea and that people didn't get sick from it. You didn't make people sicker than they were before. So that's kind of the basis of what we do today. So today we have 3 operations. We have the gastric bypass, which has been around now about over 30 years. It's about 34 years or so. The band, which has been around probably, in a lot of countries it's been around about 18 years. In this country, probably around 13 to 15 years. And the newest procedure is the sleeve gastrectomy, but even that now has been around about 10, 11 years. So these are the three procedures that we have today. And for the most part, these are restrictive operations. There's a tiny bit of malabsorption with the bypass, but most of it is restriction, is causing so you can eat less food at a time. So just to go over these so you get a little picture of these, and again, this is just so you know the anatomy. This is the liver, the gallbladder, stomach, small intestine, large intestine. Some people want to know what that is. That's the appendix, okay? So that's just your anatomy lesson. We'll quiz you on that later on. So the gastric bypass, the idea is, one is to make the stomach smaller. So we divide the stomach in half right here. So your stomach, which is kind of normally the size of kind of a small watermelon, you're converting it to about the size of an egg. So it becomes quite small. And then you need a way for food to get out. So we divide the small intestine here, and we bring this limb of intestine up and we sew it to the stomach here. And you need a way for these juices to get out, so we sew the intestine here. So it's called a Roux-Y bypass, and see the Y? It's French, so you can see the Y. That's how it got its name. And it's a surgery that we can usually do laparoscopically, where we do little incisions. There's 5 little incisions. We have to put you to sleep for all these procedures, so you have to go to sleep for all of them. This operation, if you look at thousands of patients, people tend to lose a little more weight with this than any of the others. On average, if you look at thousands and thousands of patients, people lose about 80% of their excess weight with this. Some lose all their excess weight, but on average, about 80% of their excess weight. And this operation, for a reason that we don't totally understand, tends to be better for diabetes. And we don't know why. If people are on insulin particularly, this is probably the best operation to have. It's just, it does something for diabetes that we just don't understand quite yet. The other thing is, if people have bad reflux, where they have a lot of heartburn that just won't be controlled by medications and feel like things are coming up in your throat, this operation is probably the better one if you have bad reflux, if you have significant reflux, because it helps the reflux significantly and improves the heartburn dramatically. So this has kind of been the gold standard operation for a long period of time for those particular reasons, okay? And this is the gastric band. And the idea of the band is restriction again. That's all it does. You put this elastic band around the upper stomach, and then this tube is inside the abdomen, so you don't see this tube. And this we call the port. It lies on top of the muscle, so you can feel it, but you can't see it. And the idea with the band is you can put a needle into this and inject fluid and make the band tighter, so make it harder to eat. Or you can take some out and make it a little bit looser. And the band is by far the safest procedure to do because of the fact you're not dividing any intestine, you're just putting this band around there, and it causes restriction, so there's no malabsorption at all. The problem with the band has been you don't see as good a weight loss with it on average. And for that reason, it's lost a lot of popularity in the last few years, a tremendous amount of popularity. It's, the other problem is, we see problems with the band where the band sometimes can actually erode into the stomach, or sometimes people can get a slippage where this part of the stomach will slip under the band and cause a blockage, and people have vomiting and abdominal pain. So in the last couple of years, this operation, which used to be performed about 40% of the time for weight loss, is now probably less than 5% of the time in this country. It just is not proved to be near as effective as people wanted it to be, and as years go by, it tends to start causing problems. So it's really lost popularity in the past few years. The one that has gained popularity is the sleeve. This is just shows you a band which is inflated and a band which is deflated. Not much of a difference, is there? And this is the sleeve. And the idea of the sleeve is that you just divide the stomach longitudinally like this, And this part of the stomach you remove. You take this part out. So you're changing the stomach, which again is about the size of a small watermelon, more into like a peeled banana. It's about the size of a peeled banana. So it affords restriction. Food has to come in like this, and it's trying to get through a narrower space. And then food goes down the normal channels like this. Now this one is pretty good for weight loss. On average, people lose about 75% of their excess weight. Remember I said with the bypass it's about 80? And again, this is looking at thousands of patients. People tend to lose, on average, about 75% of their excess weight, which is much better than the band, which is about less than 50% of their excess weight on average. Again, this is an operation where we put people to sleep, and again, I'll show you in a second, but we can usually do it through little tiny incisions. I think a lot of people who used to choose bands are now choosing sleeves. In this country, this is the operation performed more than even the bypass. It's not quite as good for diabetes, although a lot of diabetics, if they start losing weight, will get off their medications, particularly if they're not on insulin. If people are on insulin, that means the diabetes is worse, and usually you need the bypass to help that significantly. But if people are just on pills and are significantly overweight, they can sometimes get off those medications with the sleeve. The trouble with the sleeve as far as GERD goes, this is a very high pressure system. You can imagine food trying to get through this narrow channel, and things tend to back up a little bit. So people that have bad reflux, esophageal reflux, this can sometimes make it worse. And so if people have significant reflux, this sometimes is not the operation to try because of that reason. So if the reflux is mild and not too bad and one pill a day relieves it, then the sleeve usually works okay. But if it's significant, where it's barely controlled with medication, people feel something coming up all the time, it's probably not the right procedure to do. So with this one, there's no malabsorption. I'm going to go back to the bypass just for a second. Because food doesn't go into this little pouch here, with the bypass, there's a tiny bit of malabsorption, a tiny bit. Not so much usually with food things, because there's still like 20 feet of bowel for food to go through, but there's a lot of vitamins that are absorbed right in that area. So right in here, things like iron and some of the vitamins. So in the gastric bypass, there's about 6 vitamins you need to take. It's really crucial to take those. With the sleeve, there's about 4, and with the band, you want to take a multivitamin every day. But with this one, there's that tiny bit of malabsorption, mainly regarding vitamins. So something to know. And this is how we do these procedures. With each of these procedures, there's 5 incisions. There's 2 or 3 that are about a ½ inch long, and 2 that are just about the size of the tip of your little finger. So they're little scars, but they're not very big, and they're just little white lines. When we consent people for surgery, though, we always have to say laparoscopic, sleeve, or gastric bypass, whatever we're doing, possible open. And this is how we used to do them years ago, where we make an incision between the breastbone and the belly button. We almost never have to do that anymore. Probably maybe 1 in 100. And usually it's in patients who have had lots of surgery before, where we just can't see and get in there and there's just adhesions everywhere, and we sometimes have to open it. So we always consent people for this, but usually we can tell people ahead of time if they're going to be at high risk for doing it open. And a lot of pelvic surgery, a lot of women have things like hysterectomies and C-sections. Those don't bother us too much, but if people have had previous surgery around the stomach, sometimes the scar tissue can be pretty significant, and we occasionally have to do an open procedure. So now we get into what can happen with these. These are big surgeries. It always amazes me how well people do. Most of our patients with the sleeve and the bypass, you're in the hospital 3 nights in the hospital. By the time you go home, you're walking around. In fact, we get you up walking the same day of surgery. We get you up walking fast. You have very little pain when you go home. We put you on a liquid diet for the first week. But they are big operations. You're dividing intestine, and you're sewing things together and stapling, and things can happen. And fortunately, they don't happen very often, but they can. So these are the things that can happen that we really worry about. And every surgery has a death rate. The death rate from these surgeries, the gastric bypass 15 years ago, was somewhere between 2 and 4% at most hospitals. We never had it quite that high, but it was about 2 to 4. That means 2 to 4 people out of 100 used to die from these surgeries. And I'll get into the reasons why in a second. It has improved significantly. And I think one of the big reasons is because we do these laparoscopically now. And people are able to get up quicker. You have much less pain. And you're able to get moving and breathing. And that's really reduced the main reason for death. So the death rate now in most places is about 1 per 1,000. And knock on wood, our death rate over the past 10 years has been about 1 in 6,000. So it doesn't happen much, but it can happen for sure. And the biggest reason for deaths was because of pulmonary emboli. And pulmonary emboli are little clots that develop in your legs or in your pelvic veins. And they often will start when you're asleep on the operating room table. And then they get bigger during your hospital stay. And if they get big enough and break off and go to your heart and lungs, they can cause sudden death. And that by far was the biggest cause of that high death rate 15 years ago. And because of that, the Bariatric Society held several big meetings and said, what can we do to try and prevent this? It's a big, major problem. And it was about that time that laparoscopic procedures came out. So the first thing was get people moving quickly. And so once you're back on the floor, awake and alert, we get you up walking some. The other is prior to surgery, we give everybody little injections of heparin, which is a little bit of a blood thinner. We don't want you to bleed, but just to thin your blood a little bit to try and prevent clots while you're asleep on the operating room table. And then we put squeezers on your legs, so they squeeze your legs on and off, and those are on when you're in the hospital throughout your stay, to try and squeeze the legs and push the blood up and down to try and prevent clots. And in doing that, it's really reduced the incidence of pulmonary emboli. And the other thing is, I think between the docs and the nurses, I think we recognize it way better. So if anybody complains of any pain in their legs or their calves, we do an ultrasound to see if there are any clots. And we try not to miss it. Most of them are always negative, but we do it just to be sure. So that's reducing that. It's interesting because of the problems the Bariatric Society had with this. This is now, if you go to hospitals and you have an appendectomy or a hip replacement, you're going to get the same basic protocol. And a lot of this has come from bariatric surgery and trying to reduce the problems that we initially had. So the death rate's gone down significantly from that 2 to 3%. We do get bleeding occasionally. These surgeries are very bloodless. Probably when we do these, most of the time when you get your blood drawn every year for your physical, we probably lose less blood than that when we do the surgeries. But sometimes in the first day or two, people can get a little bleeding from the staple lines that we do to divide the bowel, or sometimes from the little holes we make from making our incisions. And we have to transfuse about 1 in every 500 patients. We have to give some blood. We rarely have to take anybody back to surgery for that. I think in all the years we've taken about 5 to 10 people back for bleeding. So it's not very common we have to go back. But I asked the people that make the staplers, how come we can't get the staplers tight enough where we don't get any bleeding? And they said if they do that, you're going to squeeze things so tight, you're going to cut off the blood supply. And then you're going to get more problems with leaks, which is another thing that we worry about. So it's a fine line between potential oozing and potential leaks. And a leak, I'm going to go back here for a second, is where the staple line doesn't heal very well, and it can occur with a gastric bypass or with a sleeve. And you get an opening here, and then it's like if you had a perforated appendix or perforated ulcer, and juices can leak out into the abdomen. And usually if that's going to occur, it's in the first week to 10 days. And it can mean sometimes going back to the operating room to try and fix that, and it can be a prolonged problem. Getting these to heal, you would think you could just go in and put a couple stitches and they would heal. It's not that easy. They tend to reopen. And it can be a long time having infections and drain tubes in and trying to get these things to heal. And again, 15 years ago, the leak rate was about again, 3 to 4%. But with better staplers, and I think doing them laparoscopically, we don't cause as much injury as we used to. The leak rate now is about 1 in 750 to 1,000. So it's rare. It's very rare. But it can happen. And just the equipment has improved significantly. So that's something we worry about technically as leaks. Things like bowel obstructions and hernias developing after these surgeries, we hardly ever see anymore, because with laparoscopic technique, you just don't see much scar tissue. The scar tissue is very minimal, so you don't get the obstructions. And the hernias, when we did them the open way, about 20% of people would get hernias within the first year. And now, with the little holes that we make, we haven't seen one in years. It's just very rare to get a hernia. Probably 1 in 1,500 patients get a hernia, so it's extremely rare to see those. So these are the main complications we worry about that can be serious, and fortunately have really decreased in frequency over the past 10 years. This we're not so proud of. Actually, now we've done about 18,000 cases here. The thing we're more impressive is just having a really low complication rate. When we get inspected, we're always right up at the top as far as fewest complications. That's the thing we're more proud of, not the number of cases, but the few complications. These are things I'm going to go over kind of quickly, because we're going to be preaching diet to you many, many times. You're going to get tired of hearing about it, of what you can eat, what you can't eat. We go very slow increasing the diet. Remember, with these surgeries, we're making your stomach smaller. So it's about a 3-month period to gradually get onto regular food. We start with liquids and go to soft foods and then gradually increase it, because there are certain foods that are very difficult to get down. A couple things I want to point out. We have a lot of young ladies here. One thing to remember after this surgery is your hormones change after this surgery. When you're overweight, your fatty tissue tends to hold on to hormones. So your hormone levels get kind of a little out of whack. When you start losing the weight, your hormone levels go back to normal real quickly. You become more fertile. And we've had a lot of women who couldn't get pregnant, didn't think they would when they lost weight, and then get pregnant in the first 6 months after these surgeries. So if you're of child bearing age, take precautions after this, because it's okay to get pregnant, but we recommend you do it after a year, because after a year the weight loss is pretty much over. But we've had a number of people call in the first 6 months, and the babies in them have done okay, but I don't think they lost as much weight as they could have. It affected their weight loss. So remember, you become more fertile after these surgeries. In fact, we've had a number of people who did this to try and become pregnant, and a number of them did by losing the weight when they couldn't before. There's only a few things you really have to be careful of in the first few months. Caffeine, we tell people to really watch, because caffeine and alcohol stimulate acid production. And after these surgeries, particularly the gastric bypass, you're a little more prone to get ulcers. We're changing the way God put things together, and you're a little more prone to get ulcers there. And alcohol and caffeine stimulate acidity, which can promote ulcers. So for the first 3 months, we have you watch those. And I usually tell people, even after 3 months, try and limit the caffeine to 1 cup a day of regular. You can do as much decaf as you want. And then alcohol, you have to be careful too, particularly with the gastric bypass. Alcohol goes into that little stomach, into your small intestine, where it's absorbed. So it's not sitting in your stomach and becoming diluted out. It's going pretty fresh into your small intestine. So the blood alcohol levels tend to go up real fast, really, really fast. And I've had a couple of people who've gotten DUIs with just a half a glass of wine. So it goes up real fast, real high, and then it comes down pretty quickly because you're not taking in that much. So remember that. The blood alcohol levels go up real, real fast with alcohol, particularly with a gastric bypass. And then these are just some things we're going to go over this. Things like corn and raisin, they just don't go down very well. And there's other foods too. With the gastric bypass, the toughest food to get down usually is chicken. With the sleeve, it's usually bread. And bread just doesn't go down through that little pipe very well. But there's a whole host of foods we'll be going over with you, things to avoid and watch. Everybody always wants to ask this one, why do we put gum here? We had a number of people early on that chewed gum and swallowed it, and then it got stuck there for a while, and so it's stayed on there all these years. So that's why that's there. The one thing that we get calls all the time from people asking, can I take this medicine or can I take that medicine? There's only one thing you really have to avoid, and this is a little tough for people that have arthritis. You have to get off the anti-inflammatory medications. Those are your ibuprofens, things like Aleve, Advil, Celebrex. Those things that can cause ulcers in anybody. And remember, particularly after the gastric bypass, you're more prone to get ulcers. And so the one medication you have to give up is those NSAIDs or anti-inflammatories. So if you're ever at the drugstore and you're picking up cold medicine or whatever, and you're not sure, just ask the druggist and say, does this have anti-inflammatories in it? That's the word you have to remember. And then you don't want to take too much aspirin, but if people take 1 aspirin a day for just to try and prevent strokes and heart attacks and things like that, that's okay, but we usually have you wait about a month after surgery and let things heal up a little bit. So those are the 2 things you have to watch out for. The main liquid you have to give up, I always tell people, don't drink juices and things like that. You want to drink things that don't have sugar in them, because sugar, you can get too much sugar in real quickly. But you got to give up carbonation. Carbonation, it distends those stomach pouches and makes them bigger. So you got to give up carbonation. It just will kill those stomachs. It makes them bigger, and then it defeats the whole purpose. These things are going to get a little bigger no matter what. The stomach's not rigid like a piece of wood. The stomach's flexible, so those stomachs get a little larger over time. The opening out of the stomachs get a little bit bigger, but the carbonation will get them a lot bigger. And then you can eat more, and then you're going to have trouble keeping the weight off. So that's the main thing you have to give up. And then, smoking. You have to watch smoking. We make everybody quit smoking 2 or 3 months before surgery. Smoking affects the little tiny blood vessels that are involved in healing. It causes them to narrow down. And it's been shown that leak rate, where things don't heal real well, is a lot higher in smokers. The other thing is, if people get an ulcer in these stomachs and they're smoking, those ulcers won't heal. They just won't heal. So you got to give up smoking and don't do it anymore. And then also before surgery, it affects your lungs and makes anesthesia riskier and more prone to get pneumonias and things after surgery. These are things you can do before surgery to help. Remember, there's more to this than diet and exercise, but that's all we have right now. We know there's intestinal things and there's hormone and there's metabolic things, but there's just not enough research been done yet to know what all those things are yet. So all we really have so far, we got our exercise and we have our dieting. So one thing you want to do is find an exercise that you have time for, you don't hate to do, because we hate to do it, we're not going to do it. And one that you can physically do. The exercise is crucial, not only to lose the weight, but to keep it off in the future. You know, we all don't like to do it too much, but we should. It's good for our heart and our lungs anyhow. But you got to find something. It's crucial to have that. And then protein, you have to get a liquid protein source, because after these surgeries, you can't eat that much. And we don't put you on chicken and meat for about 3 months. So you need a liquid protein source, and there's a lot of them out there. There's a million. I'd say probably 90% of our patients use one that you can buy at Costco and Walmart now. It's called Premier. Costco's got bunches of them. They have muscle milk. There's one at Sam's Club now, too, which is a Premier that's like a liquid. It's like a liquid. I've not tried that, but it looks like it's got different flavors. I don't think Costco itself has it, but Sam's Club, somebody told me, does. It has about 20 grams of protein. Walmart also has one called EAS. You can go to GNC stores. They have tons of them. A good one, actually, you can get there or you can get online, is called Isopure. And some of our patients who don't like milky type things, Isopure is more like a water-based thing. But you want to find a protein drink that has at least 30 grams of protein per serving and has less than 200 calories. And there's a lot of them out there that meet those criteria. But you really need to, we have people, once we see in the office before surgery, we have you start on that. And then it's really important for the first 3 to 6 months. A lot of our patients do it daily. Actually, I drink one on the way to work every day Probably wonder why I was so studly. That's the reason why I drink that protein drink every day. And then there's vitamins that you have to take. And we're going to go over that and give you a list of vitamins. Those of you, are some Kaiser patients here by any chance? And actually, other patients can get these too now. You can get it. The thing is, Kaiser patients get a pretty big break on the price. It's about half off or more. But if you get those Bariatric Advantage EA vitamins, all you have to do is those plus calcium. That's it. Whereas if you get ones, which you can do at the regular drugstores, there's about, with the gastric bypass, there's about 6 in total you need to take, and with the sleeve, there's about 4. So we'll be going over vitamins with you, but they are important, and you need to take them forever. There's a lot of studies coming out about micronutrient deficiencies in people after gastric bypass, and they come on very slowly. You don't even recognize them until you're starting to have some issues. So the vitamins are very, very important. And these are just things we go over. Remember, I think the big thing to take from this is, after you have these surgeries, remember you're not the same. When you wake up, you're different. And only in the fact that your stomach's way smaller. So a lot of our patients complain that they can't eat like they did before, and that's the whole idea. That's the whole idea. So it's much smaller. Your stomachs are much smaller, and it changes a little bit. For example, usually when people go home after these surgeries, a meal is usually about 2 to 3 ounces per meal. And after a year, usually people can eat about 1/3 of the time what they did before. So things do stretch a little bit over time. Never go back to the way they were before, but you can eat a little bit more as time goes by. So you become a little more social after time. These are just some of the vitamins that you need to take, a multivitamin, and things like vitamin B12, and there's a few more. I could go over them with you, but for example, just real quickly, I'll say for people that have a gastric bypass, they need to take a multivitamin, vitamin B1, beta-carotene, B12 that goes under the tongue sublingual. You don't have to remember all this. Calcium and vitamin D. So you can see there's a number you have to take with if you have a gastric bypass. With the sleeve, it's a multivitamin, B12 under the tongue, calcium and vitamin D, so there's 4 of them. And if you do that Bariatric Advantage EA, it's the Bariatric Advantage EA, it's just that one and then calcium. So it makes it easier than taking those 4. And if you add up the price is about the same when you only have to buy 2 things rather than 6. It comes out about the same. Particularly the Kaiser patients. Those that aren't Kaiser patients, you can get them online, but you don't get that break. So then they're a little pricier. You might be better off just taking the 6 that you can get at the regular drugstore. And then what are the benefits? The benefits are tremendous, with these surgeries, like I said. It's just, they're finding more and more, they're thinking that some cancers now may be due to obesity, and that fatty cells break off into the bloodstream and they cause inflammation, and they settle in different organs of your body. And that inflammation may stir up cancer, and things like breast cancer and colon cancer seem to be a little more common in people that are overweight. There was a study that came out of Canada a few years ago that said that if people were 100 pounds over ideal weight for more than 30 years, it probably took about 10 years off their lifespan. And that probably makes sense when you look at things like diabetes and heart trouble and high cholesterol that are possibly going to develop over time. And then we're starting to see things like cirrhosis of the liver developing in people that are overweight for prolonged periods of time, because you get that fatty liver. And again, those fat cells irritate the liver and it causes scarring. So just a tremendous number of things that are related to being overweight. Things like a lady come in the office the other day and was crying, and she hadn't crossed her legs in 10 years. She lost 75 pounds and now can do things like that. So it's little things that you don't pay much attention to. Or today, I had a lady in today. Today was my crying day. The lady came in today and said she had cancer. I said, "Are you kidding me?" She says, "No, everybody in my family has got lymph node cancer." I said, "You're kidding." And so I'm feeling her neck to see. I said, "I don't think you have any big lymph nodes." She goes, "Well, it's right here." I said, "That's your collarbone." And she had never felt her collarbone for years. So she went out of the office as a very happy person today. She was very, very happy. So these are the 3 operations, and this was easier in a way when we just had the gastric bypass before, but it's good having options and being able to choose. And what you need to do is sit down with the surgeon and go over what are your health issues? How old are you? What is your weight? And come up with what operation may be the best. In truth, a lot of people it's their choice. You take people that are relatively healthy and their BMI is between 40 and 50, it's really pretty much your choice what you want to do. But sometimes there can be reasons to do one or the other, and so it's good to have options. And that we just need to sit down with you individually and go over, what you have. And then they took away my last slide. The thing to remember, we always end this by saying, remember, these are tools to work with. They don't do everything. Everybody loses weight at the beginning. I never know how much weight people are going to lose. I always get asked that, what am I going to weigh in a year? I can tell people what they should weigh, but I can't tell you what you will weigh. And a lot depends on just the individual and to a degree how hard people work at it. So it helps you considerably, but it still requires a lot of work. So don't let anybody tell you this was an easy way out. This is just giving you help, and it still requires a lot of work on your part.